Thank you very much. Good morning, everyone. Now, when COVID broke out in Wuhan in December 2019, it was very quickly identified that the causative agent was a coronavirus, which was named SARS-CoV-2. There are 4 coronavirus genera, and 2 of them, the alpha coronaviruses and the beta coronaviruses, contain virus species that affect humans. There are the endemic seasonal viruses that cause mild respiratory disease, I've listed there, as well as those that cause more severe outbreaks, including the MERS virus, SARS-CoV-2, and SARS-CoV-1 and SARS-CoV-2. MERS is more zoonotic. SARS-CoV-2 doesn't appear to be circulating currently, and of course we're very familiar with SARS-CoV-2. In the lower left of that slide, there's a schematic showing the structure of SARS-CoV-2, and I've put it there because it shows proteins that are targets for diagnostics, things like the spike protein, membrane protein, envelope proteins. The virus was sequenced. We had the full genome sequence of the virus pretty early in the pandemic, and the diagram there shows important genes that are also targets for nucleic acid amplification tests for COVID. Now, when the pandemic kicked off, we were in not a very good place. There were initially no commercially available tests to detect the virus, and we only had published experimental protocols. And in Zambia, we had 2 laboratories that were actively working on respiratory viruses that had strong external collaborations, and we were able to set up diagnostic capacity pretty quickly. That was the UTH Virology Lab and the UNZA School of Veterinary Medicine. I mention that because I think it's important for us to know that if you have existing surveillance and research going on, it always puts you in a better place in terms of preparedness. Obviously, we had to scale up very quickly, especially the picture on the right shows how overwhelmed the 2 laboratories became very quickly. Those are samples that are waiting to be dealt with. The scale-up was faced with a lot of challenges and hindrances that I think are important for us to remind ourselves of because they're important to take into consideration for preparedness planning. There were biosafety concerns. I think a number of the frontline laboratory staff were not willing to work under BSL-2 conditions, and we started off working under BSL-3 conditions, and even when they were more reassured that they could work under BSL-2 conditions, there were issues of do we have enough equipment, biosafety cabinets, are they certified? We had a workforce that was not prepared to use the initial molecular PCR tests that we had, so we had to do a lot of training. We had to redeploy the staff to be in the right place where that equipment was available. We needed to do a lot of training on sample collection, sample packaging, and I don't have to mention the pipelines that were overwhelmed. It was difficult for us to access swabs, diagnostic reagents. Quality assurance in this type of scenario became a very big issue. We had to make sure that tests were accurate. Then the labs had to be flexible because the testing strategies kept changing. And I think one of the biggest problems that we faced is that we had weak information systems to link clinical and lab data. So at the beginning, we had very little commercial tests, but I think the diagnostic industry was magnificent. They came up with a number of diagnostic tests on the market. I think there are thousands now that can be used, but they fell into three main categories. We had the molecular nucleic acid amplification tests, or the PCR tests, the antigen RDTs and the antibody RDTs. And the table shows the sample types that are used for those tests, but I'll look more at the advantages and disadvantages. For the PCR tests, these detect viral RNA. These are the most sensitive and specific, but the disadvantages of those were that they're expensive. They required a lot of training and specialized equipment. They were not point of care, so you have to move samples around and then return results to where they're needed. And one of the biggest drawbacks was that they have longer turnaround times. The antigen rapid tests detect viral protein. These are faster, point of care, minimum training required to use them. They're cheaper, and I think one of the most important properties was that they have a faster manufacturing time. So we were able to access these much faster. They're not as sensitive, and quality assurance is a bit more challenging. The antibody RDTs, these detect the host antibody response to infection. They have a faster turnaround time, but they can be non-specific. They can detect cross-reactive antibodies from other viruses. And you can't distinguish vaccine-induced and natural antibody using these tests. So this graph, I think, is very helpful when you're thinking about COVID diagnostic tests. It shows the course of the disease. When we're talking about RNA tests, the PCR tests, these can test positive just before the symptoms appear to about 14 days or 2 weeks after, barring the issue that Professor Mlenga raised with prolonged viral shedding. Within the first 7 days, the viruses or the RNA that is picked up will point towards infectious virus that can be transmitted and cause disease. The antigen tests can test positive within 1 week of infection. And then the antibody tests, both IgG and IgM, appear between 7 to 14 weeks after and tend to peak about a week later. So this is a list of the diagnostic technologies that have been validated for use in Zambia, to the best of my knowledge. We have the molecular diagnostic tests, which include the open PCR systems, as these are the more flexible systems that can be used with different reagents. And then you have the closed systems, which only use manufacturers' reagents. These tend to be automated and high throughput. Then the rapid antibody and antigen tests below there. The ones that I've highlighted in red are the ones that were used during the pandemic in Zambia. And I think currently, for the public institutions, ZAMSA is only supplying the rapid diagnostic tests. So when we were able to access those reagents and equipment, what emerged was a national COVID-19 diagnostic network of public laboratories that were able to conduct these PCR tests across the country using platforms like the Hologic Panther, open systems like the ABI 7500, the Quant Studio, and then we had the Cobas 6800s as well. We had to have a robust sample transport system to be able to move these samples to and from. This slide doesn't show the numerous private facilities that were also offering COVID-19 diagnostic services. And it doesn't show, of course, the numerous health facilities that were able to provide rapid diagnostic testing. Now, SARS-CoV-2 has got certain features that have a bearing when we are thinking of the usage of tests and the development of testing strategies. Some of these have been mentioned before. We have asymptomatic and pre-symptomatic infections. The virus can be detectable so that community-based testing may be called for, such as screening people who can inadvertently transmit disease to high-risk individuals. The duration of infectiousness, we just saw the slide there. Viral RNA can be detected 6 days before to about 14 days or more after the symptom onset, but not all that virus that is detected is infectious. The infectious virus can be picked up between 2 to 3 days before or up to 8 days after symptom onset. So it's an important consideration when you're looking at the optimal time frame for different tests, the period of isolation. Variants of concern, they also have the effect on diagnostic testing. In the blue there, I've shown the WHO definition of variants of concern, but these can affect the effectiveness of molecular assays. Antigen tests use protein targets, so they're less likely to be affected. IgM and IgG antibodies occur earlier in SARS-CoV-2 than other viral infections, and they also appear almost simultaneously. So this can allow you to use IgM antibody in combination with molecular testing to increase case detection. Reinfection, I think it was also talked about, and that's something that must be considered. There's evidence that reinfection can occur. And then a positive antibody test can't be used as proof of immunity. So that is an important consideration. This slide just shows the testing strategy, how it evolved during the COVID response. In the beginning, the testing was of symptomatic patients with molecular tests just to refine the case definitions, to confirm diagnosis for patient management and for epidemiological studies. And then we moved on to testing for contact tracing, isolation of cases, to interrupt transmission of the virus. Initially, we used PCR tests, but this proved to be very difficult because of the pipeline issues we talked about, the access, and when the antigen RDTs became available, this became more useful. Later on, we used more of RDTs for quick tracing and isolation of contacts, and to break chains of transmission to allow reopening of the social gatherings and the economy. And we are now at the phase where testing has transitioned from a pandemic response to living with the virus, and the main role of testing has shifted from diagnosis and case detection to surveillance. So surveillance in Zambia, I think one of the main methods that we are using is the SARI ILI Sentinel surveillance system. This is a disease surveillance system that has been operating in Zambia since around 2008. It's based on a generic WHO guidelines, and it involves collection of data and clinical specimens from patients identified in selected Sentinel health facilities across the country. These are outpatients with mild respiratory symptoms or influenza-like illness. That's where the ILI come from. And patients admitted with severe acute respiratory illness, or the SARI cases. The specimens are tested for respiratory viruses. It was initially developed for surveillance of influenza, but the design of it was deliberately to be able to test for any other virus, and we've added on other viruses. And the system is implemented by the UTH Virology Laboratory, but it's part of a global system, the Global Influenza Surveillance and Response System. So the COVID-19 pandemic highlighted the need for surveillance systems for emerging respiratory viruses, and we thought that the ILI-SARI system could play an important role. The picture there is just showing how the system, although it wasn't running perfectly during the COVID response, was able to detect the different, waves of the pandemic. So plans were made, the different waves of the pandemic, while at the same time being able to show other viruses that were circulating at times when SARS-CoV-2 was not appearing. So plans were developed to expand this system to cover the whole country, to digitize it, and to expand the testing repertoire, because we knew that only over 80% of the samples were negative for flu and COVID. So there's something else that we need to be looking for. And it was also a plan that it would support genomic surveillance. These are the facilities that serve as Sentinel sites across the country. We are in 6 provinces currently. So the electronic data capture has been rolled out. We've added SARS-CoV-2 and RSV surveillance to routine testing, so we get information on that. We are doing multi-pathogen studies to see other viruses that we could add on to the surveillance system, other not only viruses, but fungi and bacteria as well. And the system has been helpful in outbreak investigations. We've detected seasonal human coronavirus outbreaks, influenza outbreaks, RSV outbreaks at various times. This is just a slide to show some of the outputs that come out of that system. This is a 2024 update, and you can see the yellow is showing SARS-CoV-2. We've had a recent surge of cases, and we are just watching that to see where it will go. Genomic surveillance has become very important. COVID-19 showed that genomic surveillance data is very important to understand public health implications. Zambia has constituted a Zambia Genomic Surveillance Consortium, a consortium of laboratories that is cooperating to accelerate the generation of this genomic surveillance data. And the approaches that we're using samples that are coming from the COVID-19 diagnostic network, although there have been challenges because it's mainly RDTs that are being used, and the quality of the samples is not as good. The SARI-ILI surveillance system, we do sequence all the samples that we get from there. There's a wastewater surveillance system for which samples are being sequenced as well. And the consortium is getting support from the University of Columbia GAP program to establish microbial discovery surveillance programs. There is also an initiative to develop a national multi-pathogen diagnostic program, and this is to target patient care to enable our clinicians across the country to diagnose patients well. This is my last slide. I'm just showing some of the reports that are given for genomic surveillance from the SARI-ILI system. If you look at the bottom, over the years from 2022 to 2024, those are the variants that have been circulating across the country. Currently in yellow, we are seeing the JN1 variant that's dominating currently, and that's consistent with what's being seen elsewhere in the world. Thank you, Chair. Thank you.